I think we're given it's 4:04, and I think we have enough people to start so that I don't take up too much of your time. So thank you so much. My name is Dr. Vineet Shah. I'm the director of orthopedics at Methodist Hospital. I'm the director of the Hip and Knee Center here as well. And I really appreciate all of you coming and listening in to the talk. We're going to talk about joint pain relief. We're going to talk about innovations in hip and knee replacement. We're going to talk about one of my favorite topics, which is pain management, after a knee or hip replacement. And we're going to talk about how does one optimize patients for surgery. And also a little bit hint on the fact of how are we doing stuff at Methodist in this COVID and post-COVID times, so we're going to kind of hit a few different topics. So I'll get started. And please, if you have questions, I know that there's a chat function on here, but as I'll be talking, it won't come up right away. If you have questions, either write them down, or if it's something that you really feel is appropriate, don't hesitate. You can interrupt me when I'm talking, and then I can stop and I can answer your question. Otherwise, if you write them down, I'll be more than happy to take your questions at the end, okay? So thank you, and we'll get started. So the topics we're going to cover, it's things like I just mentioned. So simple steps in joint pain relief, innovations in total knee and hip, something called multimodal pain management after hip and knee replacement, optimization prior to surgery. It's very important to be well optimized so that you don't end up having complications, having infections, having failures of your components. That's something that's very critical and I think sometimes overlooked. I'm going to talk a little bit about my philosophy, and then we're going to, like I mentioned, talk about how things are going on with this COVID pandemic. So let's talk about simple steps in joint relief. The key thing with any kind of joint problem is you want to try to identify what is the cause. Is the cause coming from an injury? Is the cause coming from arthritis? Is it coming from some sort of bursitis that you have in your knee or your hip? And what needs to be done for that? Was it something traumatic? Was this something because of a fall? Is it necessarily, maybe it's something that has to do with your cartilage and has nothing to do with your bones. So it's very, very important to make sure that your physician is very specific in making sure that they identify the problem before the treatment. Conservative options, a lot of us use these on a regular basis, non-steroidal anti-inflammatories, ibuprofen, Aleve. You can get those over the counter. The meloxicam or Mobic and Celebrex, those are prescribed by a physician. The last two are a little stronger than the first two, but have a better effect in terms of the arthritis, but also don't affect the stomach as much. I like those a little bit better. You have the non-medical options that you can get over the counter. You can get it at Walmart, Sam's Clubs, Costco, things like glucosamine, chondroitin, and even good old turmeric. They have turmeric pills right now, and turmeric is used in certain cooking, and it has an anti-inflammatory effect. So that particular group is something that's it's safe. It's not medications, and it does help with anti-inflammation. So that's a simple tool to try to get rid of some of the pain that you have. And then you have topical creams, right? So before you start getting into invasive stuff such as injections, you try to use something like an Voltaren gel. Or we have a pharmacy here in Northwest Indiana that creates a compound with 4 or 5 different medications. We put it on the prescription pad, and then they either call you and you go pick it up, or they mail it to you. And that covers the pain around your knee or your hip. But again, these are all temporary relief, particularly if you have arthritis. The next thing that you have as an option is injections, right? You can have the steroid, or what we call corticosteroid injections, cortisone injections, and those are given inside the knee or the hip. I highly, highly recommend that you should first meet the orthopedic surgeon and let them give you the injection. For myself, I give all the knee injections myself in the office. The hip injections, I will sometimes send them to pain management or to radiology so that they can do it under a live x-ray. People that give injections to the hips in their office, in my humble opinion, are not always getting them exactly where they need to be within the joint to give you the relief that you'd really need. So when you go to your orthopedic surgeon, they'll determine what the problem is, and then make sure that you are getting the right injection in the right spot, and that way they can monitor and see if it really did help or if it didn't. The other thing is something called hyaluronic acid injections. You may have heard about Euflexa, Synovis, Hyalgan. We have a constant problem where I have patients coming in with newspaper cuttings from somebody in Tinley Park or Orland Park who is giving these injections, and they claim they're the only people in this whole area that do that, which is not true. And they, you have to pay cash with them. These injections were popular, were covered by insurance companies, but now less and less insurance companies are covering them because they are just a Band-Aid. If you have bad arthritis, they're a Band-Aid to give you some relief to get you ready and prepare yourself for surgery. But if needed, that's an option too, which is a hyaluronic acid injection. The other thing, which is conservative, it's not invasive, is bracing, right? You can get it over the counter. There's a Mueller brace. It's called Mueller, Mueller. You get it at Walmart. I love it. It's under $20. It works well. It gives you the support you need. Or when you come to us, if you need a brace, then we can prescribe the appropriate brace. We have them in our office. We can dispense them, or we can send you to an appropriate facility to get the bracing. So that's another way to control pain when you have any kind of joint pain, particularly in the knee. Weight loss. A lot of us are thinking about anti-inflammatories, injections, all these things to get rid of pain. But one of the key things that we tend to forget is that when there's a lot of weight on your joints, your knees, your hips, your ankles, you're going to have pain. So whatever you can do for weight loss, which means diet modification, which means behavioral modification on how you're doing things. And if you can add in some exercise and do some exercise, if it's recumbent bike, if it's elliptical, whatever, or treadmill, whatever you can do to move would be critical. But the main thing with weight loss, and a lot of times people can't do a lot of exercise because of their arthritis and the pain from it. The key thing is actually diet modification. So that's something else that needs to be considered. And if you need to do that, for example, if you come and see me, you have a body mass index greater than 40, I will send you to Dr. Nakawa, who's one of our doctors here. He is board certified and specialized in weight loss management. So you still keep your primary doctor. Nothing changes with your particular doctor. All Dr. Nakawa does is take care of your weight issues. We have Dr. Ciatris, who's a phenomenal surgeon upstairs on the 4th floor from our office. He is a bariatric surgeon. So if Dr. Nakawa and Dr. Ciatris, and we feel that you are probably a better candidate for a bariatric surgery because you need to lose a lot of weight, then that's what we will offer. And that's what we have to do. And that's why here at Methodist, we work as a team. It's the three of us work together. Dr. Ciatris, Dr. Nakawa have a great relationship, and so do I with them. So we want to make sure that we can optimize you, bring your weight down, not only to relieve your joint pain, but if you eventually need surgery, you're ready to go. Lastly is physical therapy, to help get rid of some of the joint pain. If your muscles are strong, if you're able to move appropriately, you have less pain. So the last option is physical therapy. So those are some of the simple things that you can do for joint pain relief. Now, when you talk about arthritis in the knee and the hip, and when it's bad enough, a lot of people are on this particular Zoom presentation because of our bad arthritis in their knees and hips. So what are the innovations in hip and knee replacement, right? You have a partial knee replacement and you have a total knee replacement. Here at Methodist, what we offer, we have the traditional options of how to do knees and hips, but we also have computer navigation. So what that does is it allows me to map out the knee, take measurements while I'm doing surgery, and make sure that the alignment is perfect. We have everything restored to where it needs to be in a straight line. For a long time, we were doing, and we can still do, patient-specific knee replacements where we get customized blocks. Those are not as common anymore because there was issues with insurance companies paying for it. So we didn't want patients to have a bill coming to them. So we depending on the insurance, we're doing it. Sometimes we're not. And the last thing what we've done is to try to do non-cemented knees in patients. So people that have bad arthritis that need a knee replacement, most of the times everywhere else, people are getting cemented knees. We do non-cemented knees so that you can have a surgery which is a little quicker. You also have a surgery where we don't use a tourniquet to stop your blood flow, and you can have a good outcome from the surgery. And lastly, something that we're considering at Methodist in the future is to consider any type of a robotic assisted surgery. So the surgeon does the surgery, but the robot assists in terms of the alignment and everything that comes with it. When you talk about knee replacement, what are the goals, right? The goal is pain relief, restoring function, making sure stable and durable implants. Now, when I talk about partial knee replacement, this is a good image over here. On the right is a model image, and where you have the metal, as you can see right here, and the plastic, and you can see the x-ray. Where you had arthritis, you had bone on bone. And can you guys see my cursor? I think, hopefully you can.
Yes.
Yeah, so you have bone on bone right here. The black space over here is cartilage, and there is none, as you can see on the inside of your knee. Then you can go ahead and give a partial knee replacement so the patient, the knee is no longer bowed, but it's straight with a partial knee replacement. But this is a strict criteria. This particular patient cannot have any arthritis on the opposite side, cannot have any arthritis behind the kneecap. If they have arthritis on the outside or underneath the kneecap, I don't even think twice. I do a total knee replacement, because you do this partial knee, in 6 months, they're going to have pain elsewhere, and you're going to have to do a second surgery, which is a bad idea. This is what a total knee replacement looks like. You got the metal components here on the femur, on the thigh bone, on the shin bone. There's plastic right in the middle. This is the front view, the side view, and here's a image of a model of how those implants look like. When we talk about computer navigation, these are the kind of tools we have in our OR. So we have these little kind of, I call them, alien heads or ET heads. They have, the light beams that register positions on people's knees, and they get registered on the screen and allows us to know exactly the alignment of the knee, how straight it is, and how much correction we have to do to make sure that we get it perfectly aligned. So this is the navigation that we use. And this is kind of what it looks like in the operating room. We have our hoods, we make sure we're protected, we make sure the patient's protected, and we're able to do all the measurements and then check it on the screen. And as you can see, there's the screen. It shows you right here, it shows you how much bone needs to be cut. This little green nubbin on either side here, or over here, down here, it shows you what bone amount is to be cut so that you get the straight, completely straight knee replacement. This is what the robot looks like. The robot, like I said, doesn't do the surgery on its own. It's a surgeon guided robot that allows you to do the hip or the knee itself. Now let's move on to innovations. So we talked about the knee replacement. We talked about the partial knee with the complete knee, and the fact that you have to be really careful as to when the surgeon decides which knee you need, okay? So similarly in the hip replacement, we have different ways of doing the hip replacements. The goals are still the same. It's to cut down pain, to increase your mobility, to improve your quality of life, right? You might have heard of people who have a hip fracture. They break the neck of the hip. They get the hemi-arthroplasty, which is a partial hip replacement. Other people, they get a complete hip replacement like you see over here, and I'll show you other images. But one of the things I'd like to share with you is, when you look in the community over here, a lot of people are talking about different approaches to do hip replacement. The two most popular that I'll talk about is the posterior approach and the anterior approach. The posterior approach is from, as you can see on this image on the side, it's from the back on the buttock area. The anterior is right straight down in the groin area, a little to the outside of the thigh. On the posterior, we have patients lay on the sides. I make an incision like this. The scar is about, I always tell people it's like this. It's like, if you look at the screen on my image here, it's like a Texas Longhorn. That's what a normal hip replacement scar is. If you're tall, if you have a lot of fat, sometimes the incision becomes a little longer, because I don't like to stretch skin because the skin doesn't heal as well. So once that's happened, whatever muscle is detached, we are able to then repair it after the surgery, so you get back your normal anatomy. What this approach allows me to do is to really have a good view of your hip, to make sure that every bone spur that should not be there is removed after you do the hip replacement. It really gives you the best view of the hip. Can you injure a nerve? Sure you can. We take much care on how we protect your sciatic nerve when we do this approach. And that's all how we've been taught and how technically we have to do it to do our best job to protect it so you don't injure it. The point that a lot of people talk about, oh, you know, an anterior hip is more stable than a posterior hip. Unfortunately, that's really not true. If the surgery is done correctly, if the surgeon knows what they're doing and they put the cup and the prosthesis that goes in the thigh bone in the right position, you should have a stable hip. And that's what we've seen and we've shown that even during the posterior hip surgery, you don't really see dislocations unless it's traumatic. If someone drinks too much and falls and loses their balance, otherwise people do pretty darn well. The anterior hip is a technique that goes right here, as you can see this little line right in the thigh, up in the thigh in the front. And the goal is to try to get through the planes without cutting the muscles. But the problem that I've experienced when I've done this, and a lot of surgeons have, is that you have a lot of blood vessels in the front. And if you don't get control of them, you can have a fair amount of bleeding until you do. So it's a novel approach. A lot of people are doing it, but again, it should be for the right patient. Somebody who has a big belly, it's not a right patient to have the surgery because the belly is going to fall right over the wound and there's going to be sweat and it's going to be infected. If it's somebody who's a big athlete, a big muscular person, you can't really do that because you have to pull the hip around to pop it out to do the surgery. And with someone who's really muscular, it's very, very challenging. So if you ever go to a surgeon, you want a hip replacement, very important to ask them, what is the best approach for me? Because you want them to tell you why they think you should do the posterior approach or why you should do the anterior approach. So please, if you take anything away from this talk, make sure you communicate with your surgeons and ask them the questions about the two approaches. At Methodist, for example, we have something called the HANA table, which allows us to do the anterior hips very easily because it helps us dislocate the hip. So the anterior approach, this little line squiggle shows you how you go through the muscles right to the bone without really cutting the muscles. In the posterior approach, we don't cut the muscles, we release the muscles from the bone and then reattach it. So it's just a little bit different in the thought process on the approaches. So again, we talk about muscle preservation, the size of the skin scar, right? You have surgeons who will tell you, oh, I make a tiny, tiny incision to do your hip or knee replacement. To me, that is not much of a value. Because when you have a large hip component, knee component or hip component trying to go into your body space, and you have a small incision, someone has to pull the space, the incision open to get the components in. And that's when you have tearing of the muscle, tearing of the skin. I don't like that. I'd rather have the incision a little bit bigger. And I tell all my staff, reduced tissue trauma surgery, you have to be very gentle. I say the word gentle at least 15 times in each surgery, because it's very important to remind my team that we have to be gentle when we do the surgery. When you look at recovery after surgery, we are now doing same day hip and knee replacements, and my posterior hips go home the same day. If they're good candidates, they have no medical problems and they're in good shape and their family support, they go home the same day. They don't have to be an anterior hip to go home. So posterior hips are going home the same day. And at 2 weeks and 3 months, we're seeing that they're doing quite comparable in terms of how they're walking, you know, how they're using in terms of their walker versus anything at all to help. They're about even when it comes to the anterior and posterior hip. Post-operative pain, again, well-controlled pain. If you control it well, it's about the same. It is true that with the anterior approach, you have a less chance of dislocation. But like I said earlier, if the posterior approach surgery is done correctly by the correct surgeon, you don't see issues with dislocation. And both of the patients you're seeing are having shorter stay now when it comes to surgery. All my patients go home at least within 24 hours of the surgery. The day after surgery, they're on their way home, unless they're gone home the same day. So that whole trend of 2 to 3 days staying in the hospital or going to a nursing home, that is all completely gone. Insurance companies and the government decided that hip and knee replacements should not go to nursing homes or to rehab facilities. So everyone is encouraged to go home. And unfortunately, that's what we've had to do. And by preparing patients and families well ahead of time, we've been successful in doing that here at Methodist. So again, final verdict between posterior and anterior hip replacement. It's very important that the surgeon picks the right patient. Make sure they have a low body mass index. Make sure they're not too big. Make sure their pannus or their belly is not very, very large. Make sure to avoid the muscular males. In my opinion, when you do blood loss, when you do posterior hip, the blood loss is less because you can really, really easily see anything where there are bleeders. You know, with new techniques, what we're doing, where we use a medicine called tranexamic acid, TXA, when I make an incision and when I close the incision, by that, as well as a special tool to cauterize any bleeding, my average blood loss is anywhere from 50 to 125 cc's of blood loss. And if you look at a bottle of water, this bottle of water is 500 ml. So we're talking about only this much blood loss for a hip or knee replacement. And, you know, with the new techniques and everything we're doing, that's a great situation because the patient wakes up feeling pretty good and not weak. So coming to, you know, the third point is if you do the surgery right, you shouldn't have issues with dislocation. Both anterior and posterior hips should do well. If you need a revision surgery or you've had complex issues with the hip, the posterior approach is definitely better because you can see the full hip clearly. You can take any old components out. You can take any bone spurs out. But at 6 weeks, the research has shown they both do about the same in terms of outcomes. So coming to one of my favorite topics, which is pain management, right? Comprehensive multimodal pain management after total knee. So I grew up in Europe. I grew up in Switzerland, and this is a Swiss philosopher that I really like what he said. He said, you know, happiest is the person who suffers the least pain. So the motto that I've tried to use is something from my mentor, Dr. Ranawat, is no pain, no cane, no limp. That's my goal for every patient. The other goal is that the whole experience should be a seamless experience. We have a very well-oiled machine. When you come here, you know, my medical assistant, my nurse navigator, nurse practitioner who helps me, our PA, everybody's on board on how we take care of our patients, how we give you the messages that you need that are important to get through the whole process so it's seamless. So moving on to pain management. So what we are doing now at Methodist is that we do special blocks that the anesthesia department gives before surgery. So you might get one in your thigh, inside of your thigh before your knee replacement, so that you have numbness in terms of pain reduction, but you can still use your muscles. So even after the surgery, although you don't feel the pain, your muscles are still functional and you can walk. And do the same kind of thing a little higher up on your hip for your hip replacement. So both of them allow for the sensory effect, which means you don't feel the pain, but they have no effect on your motor or the ability for you to walk, which is great. The pain is down and you can easily walk after surgery, specifically because you don't have much pain. In addition, one of the key things that I worked on in 2005 and 2006 during my fellowship in New York City was a pain cocktail. This is something that my mentor actually created, and now everyone around the world is using it. And I was lucky enough to write one of the first papers on this, where like a dentist gives injection in the mouth when we do work, when I do a knee and hip replacement in the areas where there's surgical trauma, where we cut, where we do anything, I inject a medicine of 5 different things. So it's a cocktail that goes in there and addresses pain. In addition to what the anesthesia does, I do the cocktail, and then after surgery, we give you pain medication by mouth, and as well as morphine if needed. So we give you all the medication you need, but we do our best to minimize how much you get, so you don't feel groggy, so you don't have constipation, so you don't feel nauseous. We do whatever we can to avoid that. What is also important is when you're managing pain, you want to treat the patient before you do the surgery. So by the time the medications kick in, that's when you're done with your surgery. So we do that. We have oral medications, IV medications. I do not believe in doing a pain pump where people can sit there and click, click, click and try to get pain medication. I don't want that. We don't do epidurals because I don't want anyone to have any bleeds in the spine. And, you know, after surgery, we give you IV medication like something called Toradol, which is an anti-inflammatory. We give you the narcotics. We give you everything what we can, but we're very cautious how much we give because we want you to try to feel as normal as you can when you wake up after surgery so that you can get on your feet and start moving and feeling like you're ready to go home. This was a paper that we wrote back in 2007. And reviewing the data from our research, we saw that the average pain was less, the level of narcotic use was less, the ability to lift your leg up from the bed, lift it straight up and hold it for about, as long as you can off the bed. The ability was better when we did this pain management. The overall length of stay also got shorter, and more patients went home instead of going to rehab facilities. Now that's back then in 2007. Now we don't even have the options of the rehab facility. And how are we doing at Methodist Total Joint Center? We have great scores with much improved pain control. We have decreased IV use of narcotics. Our length of stay has gone from nearly 6 days to about 2.25 days. My patients is usually 1 or less days that they stay at the hospital. And we're getting more patients home than we do at rehab. Even those unique cases, pretty much 98%, 99% of our patients are going directly home. And we're trying to work really hard on the same day program. And it has been working really, really well over the last 6 months that we've been doing it. And people are going home. We make sure that they're the right candidates to go home. They don't have other medical problems and that they have support at home. So after surgery, what can you expect? People with pain and joint pain, after they have the knee or the hip replacement, they have therapy the same day. They can put all their weight on the joint, on whatever leg you have surgery. You can put all your weight. You get a walker to help you walk. You are given these special compression wraps around your legs to avoid blood clots. You're asked to blow in an incentive spirometer to really help you expand your lungs so you don't get pneumonia. We make sure that we treat you with the appropriate anticoagulation like Lovenox and aspirin so that you don't get a blood clot to the leg or to the lungs. And we're really, really, it's very important for me that my patient's wound care is very, very meticulously handled. A week after surgery, you'll come back to our office. We'll change the dressing. We'll keep an eye on it. I don't like to tell patients, okay, I did your surgery. I'll see you in 2 or 3 weeks. Because in 2 or 3 weeks, a lot of bad things can happen. And I'd rather find out if there's a problem a week later rather than 3 weeks later. So all my patients come back a week later and my staff will evaluate them. None of my patients are allowed to shower for 2 weeks. Okay, I know it sounds nasty, but a dry skin is one that's going to heal. You get in the shower, there's wet, it's moist, you get pruny skin, and that's a great area for bacteria to grow. So I like to keep the wound dry. After surgery, you'll do therapy 3 times a week and get things going right away after surgery so that we can help you really improve in a good, methodical, systematic manner with minimal narcotics and get you back to your normal self. So, talking about my philosophy, it's very, very important that there's, I'm just jump to number 2. There's a family conference, right? To me, it's very important. I just told the patient today, it's them, their family, and then the surgeon. So it's a triangle. It's a trifecta. All 3 people have to be involved in the care of the patient. All 3 people have to know what we have to do for the care of the patient. Because if you have a family member that doesn't know and they're supposed to take care of the patient, get ready for problems. So we don't want that. So we make sure that we have a family conference with all our patients who are having surgery, so everybody's on board and everybody's on the same page. We do a joint class that's run by our nurse practitioner or the PA, and they go over all the details of surgery. And now, because of COVID, I created a video where I talk about everything. And when you book your case, you get a little QR code that you can just put on your iPhone and you can hear my video and it goes through everything in detail regarding the surgery. Also for me, like I mentioned to you earlier, pain management, to use minimal narcotics has always been a passion. So that's something that I really think is part of my philosophy. And one of the things that I really feel is critical is that there has to be a clear line of communication between the patient, the family, and the doctor. If you guys have a question, you call, we respond. It's very important. If you have a same-day surgery, all my patients get my personal cell number and they can call me through the whole night. The idea is if they have accessibility to us, if there's a problem, we can tackle it right away instead of them going to some emergency room and sitting there for hours and then getting sent home. So communication, very critical. We really work hard at it and are really proud of doing a good job with it. So when you have joint pain and you go through knee and hip replacement, there's so many different messages that you get around, right? On the internet from friends and family. Oh, you got to have the surgeon that does the smallest incision. That means that they know what they're doing. That's not really true. You know, minimal skin incision versus minimizing the skin incision are two different things. For me, I start off with an incision this big, and if I need to make it larger, I will. If I don't, I leave it at that. I don't do a little incision and force my whole surgery, causing trauma to the tissue. And that's why the whole concept of reduced tissue trauma, that second point, is very important. You know, if you do a reduced tissue trauma surgery, you're gentle with the skin and the muscles, you have better pain management. And then with everything that we do with the blocks and that multimodal injection and the pain medications we give, people do really well. When I do these cementless knees, I'm one of the only surgeons in Northwest Indiana that does the whole knee replacement without even putting the tourniquet up. So your blood is flowing all the time. The chances of blood clots go down. And we can do a cementless knee and give you really good results. Another topic which is very important, and doctors sometimes don't do a good job of it, but patients sometimes forget that they need to be at their A game, you know. Surgery is a big deal. You have to understand everything, the risks, the benefits, talk to your doctor, get to know your doctor, get to know their philosophy. But you want to be ready and in the best shape that you can be to go through the surgery. That's why optimization is very critical. Diabetes, for example, want to make sure that your blood sugars are well controlled. Your hemoglobin A1C is within what our limits are, is 8 or less. We want to make sure that we work with your primary care physician to improve this. If you need a nutritionist or an educator referral, we got to make sure that we provide that to you or have your primary care physician provide that, because we want to make sure that that is controlled. Tobacco use is another thing. We do provide a cessation program where people can try to stop smoking. When you don't stop and you smoke, the wound can have compromise and it's not worth it. So we work really hard with the patients to try to have them stop smoking. Weight loss, obesity, very critical. You have a large BMI, you have a BMI over 40, I don't operate on you. If you go to Chicago, their cutoff is 30. So you're talking about people who are really light. They won't operate anyone above 30 because they're worried about infections and failure. Us here in Northwest Indiana, we push it to 40, but not above that. I think it's a bad idea to do anything above that. Why not send them to Dr. Nakawa or Dr. Ciatris, and they can address the weight, get the patient optimized, like I said, send them back to me, and I can do the surgery. Patient has a better outcome, they're lighter, they're easier on their feet, and they feel good. And lastly, malnutrition, right? I talk about obesity, but we also have a problem of malnutrition. Malnutrition doesn't always mean that you're eating less of a food. It can be more of a bad food too. So it's very important that you have a good protein intake. And I talk to patients and their families about what can you eat around the area, what's staple in the area. You know, what are the options that you have for healthy food instead of going to McDonald's or going to Little Caesars or something like that, right? You look for those foods that are well worth it. So that's something else that's very important to get you optimized and ready for surgery. Prior to surgery, we're going to send you for medical clearances. We want to make sure that your medical doctor, your cardiac doctor, pulmonary doctor all check you out, make sure your heart and lungs and everything is good. If you got dental issues, you got any kind of cavities, any kind of abscess, we want to make sure the dentist evaluates it, cleans it before they send you back for surgery. We want to make sure your home is safe. You know, we'll talk about that. We'll talk about making sure that you get rid of the little carpets that you can trip over. Want to make sure that you have the right support and help inside the bathroom when you need to get up. And one of the things I really find very fascinating is something I call prehab. Rehabilitation or rehab is after the surgery, but it's very important to get good results with arthritis and joint pain with knee and hip replacement if you are strong before the surgery. Once that you accomplish that, your outcome will be so much better because your muscles are strong, your lower leg is strong, your upper arms are strong, so you have a better outcome that way. You know, at Methodist, we had some fun just before COVID, and then we had to stop. We did a research study. This is called a QB. It's a little under the desk elliptical, originally designed for people working at home or at work to put that under the desk. Then they could do the range of motion, but their knees would never hit the table. Well, we took this and try to use this for hip and knee patients, and patients have loved it. They use it before the surgery. They use it the day after surgery in our hospital, and then they use it at home. And it really feels positive, and the data that we've collected thus far has been also pretty optimistic that this has great value. And during COVID, we were very careful about how we did everything. All the patients and staff are still wearing masks. The rooms are cleaned thoroughly. We were doing COVID tests on all patients, but if you're vaccinated or have had recent COVID, there are certain rules and regs. Unfortunately, I'm not going to say much on it because it's very dynamic. It changes depending on the COVID numbers, but we're right on top of it, and we do what's the right thing based on the CDC. The education lecture that you get with my nurse navigator or my physician's assistant, I have done that whole lecture myself, and you can see it. We provide a QR code, and you can scan it and watch it with you at home with your friends and family, so that you know exactly what to expect when you go through a hip and knee replacement surgery. Again, with people with COVID, they're asked to try to stay away from large groups and things like that at least 72 to 96 hours prior to surgery, so there's no issues of them having an infection on the day of surgery. Our goal is to protect our patients and our staff and make sure that we have healthy healthcare workers so that people can be taken care of. And we have our nursing floors, we're split up by COVID areas and non-COVID areas. So if you're ever thinking of coming to Methodist for doing hip or knee replacement, we're ready. We're able to take care of you and do that in an efficient manner and in a clean manner. So thank you very much for listening. If you have any questions, please call our orthopedic clinic for appointments. We have Michelle Moniak, our operations manager, our director of orthopedics, and she'll be able to also guide you, get you appointments. So feel free to do that.
Dr. Shah, I just want to let everyone know that I will be sharing a video of this on YouTube, and I'll also share the link to schedule an appointment with Dr. Shah directly on the internet.
Great, thank you. So yeah, thank you very much. That's the end of the talk. I wanted to talk about joint pain. I wanted to talk about what can be done for it. And I want to tell you how we do it here and how the goal in my practice is to be very methodical, to be systematic, to do things the same way. It's not about doing a fast surgery. It's about doing a perfect surgery. That's the critical mantra that I really live by. You want to make sure that you have good, reproducible outcomes so patients have a better quality of life. So thank you very much. And I'm open to taking any questions if you have some. If you don't, please feel free to reach out to us anytime if you have any other questions, please.
And just to add to what Dr. Shah said, if you have any questions that come up in the middle of the night or anything, just respond to that corporate communications email, and I'll make sure they get passed along to Dr. Shah.
Dr. Shah.
Yes.
I was wondering, even with that less than 125 cc's, you said you wouldn't have to take blood with that type of loss, would you?
No,
because I don't take blood.
No, absolutely not, ma'am. I'll be honest with you. In the last 4 or 5 years, I think I've had to transfuse blood one time, if maximum twice. I don't even think it was twice. It was once. And actually, again, I don't know, your religious background, but there's a fair amount of Jehovah's Witness community here in Northwest Indiana, and I've been really fortunate to take care of a lot of the Jehovah's patients here. I have a rapport. I have a connection with one of the pastors here, so him and I have met, and I've learned a lot about the beliefs, and we do everything that we can to respect that. And I treat even every Jehovah's patient I treat as an individual, because sometimes people have different opinions of what kind of what they will accept and what they won't. So I don't just do a generalized thing. It is done specific to each and every individual.
Do you have that cell salvature in there by choice or if the patient asks for it?
So can you say that again?
The cell salvature?
Yeah,
you
yeah,
have
cell
it?
saver. Yeah, so some of the Jehovah's patients like that, they'll say, listen, if you're gonna suck up the blood from my surgery, put it in a container and then get it back in without it leaving into the atmosphere, right? We're fine with that. We'll take that blood. So some of them will allow me to do that. And yes, we have the cell saver. Some people will say, absolutely not. Once you suck it out of my body, I don't want it back. Fair enough. So, that's the time where I make sure I optimize the patient, make sure we have the hemoglobin as high as we can get it. And when we do surgery, everybody in the room, every member of my team knows very clearly, this is Jehovah's Witness patient. This is what the limitations are. We're not rushing through the surgery. Everything has to be done step by step, methodical, so we have as little blood loss as possible.
Thank you, doctor.
Yes, ma'am. Any other questions? I'm here. I'm willing, more than happy to answer anything.
Dr. Shah, there was a question on chat.
Oh,
Question
let me
from
try to go there.
Kwame. How do you feel about surgery on both knees? And then the second part of it was, what is used in place of cement for the cementless knee replacements?
Awesome questions. I love that. So, I have done both knees at the same time. The patient has to be very healthy. We don't want to have patients that have heart issues, lung issues, anything like that. They are not good candidates for surgery. If the patient is, large or overweight, they're not good candidates. But if you have bad arthritis, you're a good candidate. Yes, I will do both knees at the same time. I did a 23-year-old young lady who had horrible arthritis for many reasons before, did both her knees at the same time. 8 weeks later, she is now working for DoorDash, driving around, delivering meals to people and living her life with her 2 daughters, so she's back to her normal life. So yes, you can have both knees done, but again, ideally you do one knee replacement and you wait 6 weeks, feel better, and then you do the second knee replacement. To me, that's the ideal way to do it. And if there's a specific reason why you want both done at the same time and you're a good candidate, I'm more than happy to do that. When it comes with the question about cement versus cementless, the beautiful thing about the technology now is the back of the components have a coating. The cementless components have special coating. Once you put it into the bone after a little while will start growing into those little beads that are within the component. And you don't have to put anything. It's just you impact it right onto the bone and it stays there because you're actually putting weight on it when you're walking, right? So the chances of it popping out are less because there you have the 2 bones against each other. So in cementless knees, we don't put anything. The components are created such that they are inviting bone growth onto the components, and that's how it stays fixed for a long time. And the patients that I've done that are cementless, I see them now, they're 4 or 5 years out, and they're super happy and doing really well with great stable knees. So those have been good fun surgeries to do with good outcomes. Yes. Thank you, Mr. Lee or Miss Lee.
Dr. Shah.
Yeah.
Dr. Shah,
Yes, ma'am.
I was just wondering about how long does a knee replacement take?
How long does it take to do a surgery?
Yes, please.
It can take anywhere from an hour and a half to 2.5 hours. Okay, you'll have doctors who will say, oh, I do it in 45 minutes. I do it in 50 minutes. Speed doesn't make quality.
Right.
Attention to detail makes quality, right? A lot of people will say, oh, that surgeon's really good because he does the surgery fast, but does he really or does she really do that? When you have a fast surgeon, doesn't mean you're a good surgeon. Are there good surgeons who are fast? Absolutely. But that, to me, those are few and far between, The key thing is to do it methodically and do it in a good pace. You don't sit there and dilly-dally and do it for 3-4 hours. No. But you want to make sure that your x-rays and your outcome is such that when I take a patient surgery, I'm thinking only one surgery. I'm not thinking, let's do it quick. If it doesn't work out, I'm going to take them back to surgery. That's not how the thought process should be. Does that answer the question?
Yes, it does. Thank you very much.
Thank you, ma'am. Any other questions? Okay, well, thank you. Hold on, I think maybe there's one.
There was a comment that they like your approach, Dr. Shaw, and I just want to thank everyone for joining us tonight, this evening. Hopefully everyone stays well. It looks like the weather turned on us. But if no one has any additional questions, we can wrap it up and everybody can go about with their evening.
Yeah, and please feel free, I left these numbers up, and even if even if you go to another surgeon or you have somebody that you go to, but you want to have a second opinion and come and see me, I'm always open for that, okay? Because to me, the philosophy is this, that it's about the patient. It's about making sure that you guys have a right outcome, right? That's what our job as a doctor should be. Yes, we make a living doing surgery, but if you want a second opinion to feel comfortable, and then you decide who you want to use as your surgeon. And if you go back to your original surgeon, I don't have a problem with that. I want to make sure that your questions are answered and you feel satisfied, and we take pride in the quality of work we do here in my practice. And, I have a nurse practitioner, Lena Anderson. I have a PA, Jimmy Garala, and my medical assistant, Sherry Counts. These are integral part of my team. I am nobody without them. We work together as a team. My patients are their patients, and everyone is on the same page. So that's what makes our practice, it makes it a lot of fun. We have a good time, and we try to take the best care of patients as we can.
Thank you, Dr. Shah.
Thank you, everyone. I'm really grateful for the opportunity, and please reach out to us if we can do anything here at Methodist.
Dr. Shaw,
Yes,
one more question, please.
please.
As far as a knee replacement, if a person is having a problem with their knee, should they take the steps before replacement, say cortisone, and then a shot of some substance before contemplating a knee replacement?
I think the first thing you need to do is to go talk to the orthopedic surgeon and get x-rays, right? You want to really know how bad is it. If you have bone slammed on bone, right? I don't know if you see my hands, right? You don't have that space of cartilage, you have bone slammed on bone. The cortisone injection or even the gel injection is not going to do anything. Right? I tell patients it's like having two pieces of wood with strawberry jelly in the middle, and you slam it, the jelly is going to go everywhere. It's really not going to support, because the knees and the hips take all our body weight, right? So get the x-rays first.
Okay.
And then take the decision. If you get a cortisone injection, you might get temporary relief, but listen to one thing, sir, that I say very carefully. I'm not talking negative about other orthopedic surgeons, okay? But a lot of people love giving injections. When you take a needle from the outside and put it in a sterile knee or a hip, you always have a very small chance, but you have a chance of creating an infection or bleeding. If you have bad arthritis, I'm not going to waste my time and your time. I mean, I get paid for giving the injection, but if it's not going to help you, it doesn't make sense. I'd rather spend the time and talk to you and your family about what are the other options and what are we going to do to fix your problem. So 3-4 weeks from, whenever we do your surgery, 2-3 weeks after that, you're walking around with no pain, no cane, no limp. One of our own staff members, who's like 6'4", 275, 280 pounds. I did his hip 2 weeks ago. He came to clinic with his wife today, and all of us are looking, going, where's your cane? Where's your walker? He forgot it at home, right? So if it's done the right way, my point is he was limping so bad, and now he's without a limp.
Gotcha.
So, to just do the right thing, just make an appointment with an orthopedic surgeon, and then we can help and guide you.
Okay. I'll make an appointment with Dr. Shaw.
Yeah, please do. The numbers are right up on the screen. I'm more than happy to do that.
You did a good job with my thumb.
Okay, good. That's right. Okay.
All right. No
Thank
other
you.
else?
Any other questions? All right, well, thank you, everyone. Thank you for the opportunity. And I will look forward to seeing any of you if you have any questions. And have a wonderful evening, and I will be available anytime.
Thank you, Dr. Shaw. Bye.
Bye. Thank you, everyone.
Bye, Dr. Shah.
Bye.